Morehouse School of Medicine is so excited to partner with Meharry Medical College and Ashland Management Group in partnering with small community grassroots organizations to transform how we think about building bridges between healthcare and health. It is so important that Morehouse School of Medicine participates in this consortium because we are a trusted voice in the community. We, like other institutions, particularly grassroots organizations, have really understood that people need to hear from people who they know in the community. There's a sense of trust and engagement that comes from those relationships that have been built over the years, period. And we figured out that particularly during this vaccine hesitancy component of the pandemic, that it was the fact that we had been in the community previously that made all the difference to why someone would choose to move beyond their comfort zone to get a vaccine. And it was because they had heard our voices when there wasn't a pandemic. They had heard our voices when they were trying to get access to care. They had heard our voices when they were trying to understand about some unknown diagnosis that came into their family, like cancer or some communicable disease. And we were the ones who were there and have been there to explain the opportunities for access to care and access to the most transformational therapies. So we've been there when others have not been. So when we came during this pandemic, we were able to decrease the amount of vaccine hesitancy. But I would add that we still have more to do because we know there's still somewhere around 25% of people who are not vaccinated. And we know that this pandemic may have moved to an endemic, and it will continue to require that we are fully engaged with the community to bring that other 25% along so that we can eradicate this COVID-19 pandemic and endemic.
Introducing Dr. Arletha Lizana Livingston from Morehouse School of Medicine, who's the Associate Professor of Family Medicine, Director 2 in the Innovation Learning Laboratory for Population Health, and the PI for HRSA HealthWorks. Dr. Lizana.
Good morning, everyone. Good afternoon, I should say, and welcome. I'm Arletha Lizana, and I'm honored to serve as the Principal Investigator for the HealthWorks Health Resources and Services Administration, HRSA, community-based workforce to build COVID-19 vaccine confidence project supported through President Biden's American Rescue Plan. So this summit marks the end of our initial 9-month effort to strengthen vaccine confidence and to provide culturally competent information and education on vaccines and improve rates of vaccinations across Georgia and Tennessee. Through the collaboration with Meharry Medical College, Ashland Management Group, Morehouse School of Medicine, and a host of community partners, we have mobilized outreach workers to provide critical information and to encourage initial COVID-19 vaccinations and boosters for the most vulnerable and medically underserved communities, including racial and ethnic minority groups. The HealthWorks approach includes community outreach worker recruitment, training, and deployment, small business rapid training and technical assistance through small business ambassadors, encouraging COVID-19 vaccination of community members and small business employees and families, opportunities for vaccination of employees at larger businesses, and focused COVID-19 messaging, marketing, and communications. As such, our goals for HealthWorks are to establish and train a statewide workforce of community outreach workers in Georgia and Tennessee, deploy 220 community outreach workers in Georgia and Tennessee to conduct 20 vaccination administration events, to vaccinate 15,000 residents by the end of the project, increase vaccine uptake among the small business workforce by training 200 small business ambassadors, increase uptake, vaccine uptake among employees and relatives of employees at potential super spreader businesses, and use data-driven strategies to improve COVID-19 vaccine uptake among socially vulnerable and medically underserved populations and communities. So the next slide is about it's a shout out to all of the HealthWorks consortium members. Without you, none of this would be possible. So thank you very much. Next, we will have a greeting from the two site principal investigators, Dr. Paul Juarez from Meharry Medical College and Dr. Ebony Haynes from Ashland Management Group.
I'm Dr. Paul Juarez. I'm professor and vice chair for research in the Department of Family and Community Medicine at Meharry Medical College, and site director for the HRSA-funded HealthWorks program. Today, you are going to hear about HealthWorks and some of the successes and lessons learned through this collaborative effort between Morehouse School of Medicine and Meharry Medical College to increase COVID vaccine uptake among racial and ethnic minority and other disenfranchised persons who have borne the brunt of the pandemic since the beginning. HealthWorks is an innovative collaboration between two historically Black medical schools to provide trusted voices in our respective communities. We each trained and deployed community health workers, engaged small minority businesses, partnered with mobile vaccine providers, and use our established networks of community partners to reach, educate, and provide COVID vaccines to persons in their communities by persons from their communities. The success of this approach of taking the vaccine to the community has been validated by the thousands of COVID vaccines that we have been able to administer to date. Thank you for joining us here today. We look forward to sharing our efforts and successes with you.
Greetings, everyone. I am Ebony Haynes, co-principal investigator for Ashland Management Group. Ashland Management Group is a small business administration certified economically disadvantaged woman-owned small business with an over 25-year history of providing management consulting, data analytics, and other services to local, state, and federal governments, private and nonprofit organizations, as well as universities. In late 2020, Ashland's CEO, Linda Botts, whom you'll hear from later in today's program, presented a very important question. How can small businesses, particularly minority-owned small businesses, be engaged in meaningful ways within local communities to help address COVID-19 or any other public health emergency that we might find ourselves in the future? In early 2021, she and the Ashland team pulled together a national webinar where representatives from the CDC, CDC Foundation, FDA, NIH, Wharton School of Business at the University of Pennsylvania, and others discussed strategies to connect small business to public health. So here we are. Those initial conversations really did help create a pathway for us to begin engaging small minority-owned businesses in a public health effort. So during today's summit, you'll hear more particularly during concurrent session B, about how we recruited, trained, and deployed small businesses to help us reach communities most at risk for COVID-19 infection and hospitalization. In my opinion, we're changing the landscape in terms of what public health practice looks like in the United States, because HealthWorks has created what we believe to be a model for public health practice that can be implemented in local communities nationwide. And it has truly been a pleasure to co-create this model with Morehouse School of Medicine and Meharry Medical College, as well as all of our consortium partners. And today, we are excited to share all of our lessons learned with all of you. So thank you for joining today's summit, and we look forward to engaging you in our sessions.
Hello, everyone. So I'm back again with the call to action and our next steps. Do we have, I'm sorry, I think that, did we have one more? Are we ready for me? I think we're ready for me. Okay, thank you. So hello, everyone. This is the call to action. It's the time where we ask our partners and supporters and community activists to help us get the job done. We know that the COVID-19 pandemic hit minority underserved population communities the most. I know we're all tired of hearing about COVID-19, but we can't afford to be tired right now. So why? The United States, the official COVID-19 death toll has now surpassed 1,060,000 deaths. The total cumulative data shows that Black, Hispanic, American Indian, or Alaskan Native and Native Hawaiian or other Pacific Islander people have experienced higher rates of COVID-19 cases and deaths compared to white people when the data are adjusted to account for differences in age by race and ethnicity, meaning we still have work to do. Community health innovation has been my passion actually for as long as I can remember. I'm originally from Pittsburgh, Pennsylvania. I remember being about 6 years old and attending the Black Solidarity Fair and learning about staying healthy and also having birthday celebrations at our neighborhood health center. It was on the corner of Hamilton Avenue and Sterrett Avenue in Homewood. My aunt Sissy was a nurse there, and my father, one of the first Black police officers in Pittsburgh, worked there at a substation adjacent to the center. The Alma Illery Health Center is actually still in existence, but that's not the case with many other urban and rural health centers. As a student at Spelman College and then later at Temple University, I always wondered what happened to those neighborhood health centers. What happened to family and community all working together to help us be healthy? It's really the community part for me. So what we saw over the past few years of the revival, of what community means. So coming together, to band together to, help our community be healthier. So this summit's focus is on our lessons learned through the HealthWorks initiative to deploy community outreach workers, community health workers, business ambassadors, and college ambassadors to mitigate COVID-19 and health disparities in our communities. Specifically, how community efforts are central to better health in all communities. We hope the lessons learned through the HealthWorks initiative will be helpful as we all continue to band together to advance health equity. We are thankful for your attendance and value your input. Next, we will have a panel discussion addressing COVID-19 related health disparities and advance health equity by mobilizing community outreach workers to educate and assist individuals in getting the COVID-19 vaccination. And then a little later this afternoon, we will have breakout sessions to discuss in detail the HealthWorks blueprint. So again, thank you for joining.
One thing that I'm excited about in terms of the community health workers is that we've known for a long time that messages are meaningless unless the messenger is trusted. So by taking people from communities and training them up as community health workers, we've solved a major problem because we have somebody who's from the community, of the community, conveying those messages. They're going to be much better received and internalized. The other thing is community health workers have the potential for engaging and inspiring others to want to become involved in the healthcare workforce. And we know, as you're probably aware, that when the healthcare provider workforce reflects the people they're taking care of, outcomes are better. So I think on that basis as well, having community health workers from the community is going to be beneficial on lots of levels. And I think is a really exciting part of this program that we're involved in.
Introducing Dr. Donald Alcindor, Director of Research for Tennessee SEAL and HealthWorks Tennessee, Associate Professor of Microbiology, Immunology, and Physiology at Meharry Medical College in Nashville, Tennessee. Dr. Alcindor.
Yes, so thank you for having me. We have a distinguished panel for this session. I'm going to start with Dr. Arlita Lozana. She's an Associate Professor in the Department of Family Medicine, Director 2 of an Innovation Learning Laboratory for Populations Health. She is the PI of the HRSA HealthWorks at Morehouse School of Medicine. We have also Dr. Christopher Irvin. He is the Director of Community-Based Health Initiatives in the Department of Family Medicine at Morehouse. And finally, we have Dr. Kimberly Lamar, who is the Assistant Commissioner, Office of Minority Health and Disparities Elimination for the Tennessee Department of Health.
Thanks, everyone. Next slide. Thank you, Dr. Alcindor. So your participation in HealthWorks has been invaluable. So I really appreciate you moderating this session. So I am a community health worker advocate, supporter, and champion. Morehouse School of Medicine really has led the way in promoting and implementing the idea that community health workers are an important part of the solution. MSM currently employs community health workers as trained community health workers, outreach workers, promotores, and lay navigators for over 25 years. To date, MSM has trained more than 1,000 community health workers in a variety of settings, community, clinics, academia, and in many healthcare areas, such as diabetes, cancer control, and reducing emergency room visits and rehospitalizations. We even train high school students to be junior community health workers for their peers and family. The purpose of the HRSA community-based workforce to build COVID-19 vaccine confidence program is to address COVID-19 related health disparities and advance health equity by mobilizing community outreach workers to educate and assist individuals in getting the COVID-19 vaccination. The program's funds are to be used to mobilize community outreach workers, assist individuals in getting the vaccination, and to address COVID-19 related health disparities and advance health equity. Community outreach workers include community health workers, of course, business ambassadors, college ambassadors, patient navigators, social support specialists, and anyone that's doing targeted outreach in communities and in businesses. Next slide, please. Our HealthWorks community outreach worker rapid deployment model is simple. We recruit, train, and deploy. So we recruit those with experience and even those without experience who just have a passion for helping out in their communities. We train them to do outreach in their communities and to provide information and encourage vaccinations and attend vaccination events. The training consisted of short courses, a couple training platforms, in-person, live training, monthly strategy sessions, and continuing education. So we deployed the outreach workers, community health workers, business ambassadors, and the purpose of this initiative is the focus on outreach workers, and it's because of the potential for rapid deployment. This community-based workforce, once trained, can quickly be deployed. We always tell the outreach workers to start with your circle of family and friends, branch out to your church, organizations to which you belong to, such as fraternities and sororities, and then to your neighborhood and even businesses in your neighborhood. Meharry Medical College recruited community health workers through its extensive CHW network in Tennessee. Morehouse School of Medicine developed a shorter, rapid-trained outreach training course and recruited through our community engagement network. Ashland Management Group recruited business ambassadors in Georgia and Tennessee through their business networks. And Black Girls Health Foundation recruited college ambassadors in Georgia and Tennessee. So this slide is too busy for you to read, so I don't expect you to read all of this. But what I wanted to show is the overview of the HRSA data collection requirements and the types of data we are collecting. And this is important because data drives how we're able to recruit, train, and deploy outreach workers, as well as what areas we should focus our engagement efforts. So we have 4 HRSA surveys. The first survey, the profile survey, is completed by outreach workers as they are recruited. It comprises demographics, vaccination status, experience as an outreach worker, and activities and resources the outreach worker plans to use when they do outreach. Outreach workers also complete the outreach form every day they do outreach. This survey covers location and method of outreach, description of persons receiving outreach, and the community member response to the outreach. The last 2 surveys are for those who are being vaccinated or boosted. The questions cover demographics, reason why the person may have hesitated or delayed in getting the shot, and what information, if any, they received that made the difference in their decision to get the vaccination. We also provide a monthly narrative report to HRSA and collected additional survey and focus group data. We have a wealth of social media, print materials, and other assets. So in the breakout sessions later this afternoon will be elaboration on the details. So I'll hand it back to Dr. Alcindor. Thank you.
Yes, Dr. Lozana, I have a couple of questions. I'd like to know what did your team do to approach serving those diverse populations in Georgia to try and deal with misinformation that was causing people to be more hesitant when it comes to getting the COVID-19 vaccine?
Right. So we did a number of things, along with working with Georgia Seal, and you'll hear more about that this afternoon. So along with developing specific material for specific populations, a lot of it also had to do with the training of the outreach workers, right? And so the outreach workers, are the frontline force, the people on the ground. So the people that you see, at your supermarket, at the gas station, around. So we really train them to engage with people and really just talk to people. So when you start talking to people and it seems, like informal, people will tell you, what their beliefs are, and we found, of course, a lot of people know this over the past few years, that people are very vocal about what their beliefs are, reasons for getting vaccinated and reasons for not getting vaccinated. So we trained the outreach workers to really kind of tune in using motivational interviewing to those questions and comments, that community members had, and be ready with responses. So I would say that, really made the difference for us.
Yeah, we know that going back to school was very traumatic for all of us that are parents, and getting children back to school safely was our primary concern. And so I want to know what the Georgia Seal and HealthWorks Georgia did to try and ease the stress of parents bringing children back to school, and at the same time, trying to get them vaccinated.
Right. So we had, again, a number of efforts. So, working with Georgia Seal, providing infographics, to those parents, really to help them kind of understand what the risks are for their children going back to school and why they need to be vaccinated. We have pediatric vaccination clinics that we run every Tuesday and Wednesday that are through Morehouse Healthcare. We did flyers and giveaways, of course, for those things. So we have some really cute giveaways, backpacks and, diaper bags and things like that. And we really just tried to make the parents comfortable, again, through the outreach workers, through other community events, through our MSM partners, as well. So anything that we can do, provide webinars, answer questions, anything that we can do to make the parents feel comfortable with the vaccinations, that's what we did.
Yeah. And so, Dr. Lozana, we know that 8 out of 10 people that have died of COVID-19 were 65 years and older, making older Americans among the most vulnerable populations for COVID-19. What have your group, your team done to basically approach the elderly community to motivate them to post-vaccinate and to both stay up to date on their boosters?
Right. I think some of the same things were employed, of course, with the outreach workers, but it's something that MSM, kind of did early on as well. So you saw Andrew Young, so he was a big advocate for telling, older people, just telling all generations that they need to get vaccinated. And what we saw is that the older generations, they really were some of the first in line, so they recognized this, I guess, living through, some of the health disparities for so long, they recognized that they needed to be vaccinated quickly. They're also first in line for the booster. So, we've seen that they've led the way.
Yeah. What we've seen recently is a dramatic change in terms of the formulation of the vaccine to incorporate a bivalent Omicron booster. And of course, when we look at it, less than 5% of people have come forward to engage and accept and take the Omicron booster. And so what are you doing in terms of trying to encourage people to take this booster, because we think that it's very good against the current viruses that is in circulation?
Okay. I'm actually going to punt that one over to Dr. Irvin. So that's his area. So some of the answers that I'm actually kind of taking over some of his, what he would say. So I'm going to punt this to him.
Okay. And so the other question I have is the Black church. We know that the Black church is the foundation for people meeting, engaging on a regular basis. And of course, even during the COVID pandemic, people attended church. Unfortunately, we lost some people that were church folks. And the idea is, what are you doing to try and incorporate the Black church in terms of engagement, community engagement, and of course, vaccine confidence and uptake?
Yeah, absolutely. I mean, so of course there are some of our primary partners. So a lot of the events that we do on the weekends they're at churches. We just did a community engagement day, last Saturday. That is sponsored by church, in conjunction with Morehouse School of Medicine. And so again, you'll see that they are very, happy, to partner with us, to do events. Also, again, specific engagement training for the outreach workers. As I mentioned early on, that's some of the first things we tell the outreach workers. So not only engaging, your family, immediate family members first, but also beginning to engage the churches, so, talk to people, try to get on the program and talk about HealthWorks, pass out information and so forth. So I would say, that the church community has been a partner since the beginning.
Thank you so much.
Good afternoon, everyone. And I'm not going to necessarily have a slide deck, but this is a great segue to some of the questions that Dr. Lizana was asked and answered from Dr. Alcindor. And so my role in this has been really to sort of talk about the impact HealthWorks has had within the community, particularly with getting people actually vaccinated. With my role, it's taking, our various healthcare providers who operate at the community level. So some of our Morehouse healthcare staff, some of our team members, and even our students through our MSM Hill Clinic, Health Equity for All Lives student-run clinic, truly engaging the community that Dr. Lizana has just mentioned. So partnering with the health workers that have been brought in through HealthWorks, it's how do we now actually have that impact? And some of the things that we've noticed is, one, that there is an interesting community that sort of divides those who want to be vaccinated versus those who just have not been able to get vaccinated. And there's been a great intersection there. As was mentioned, like the churches, we had great engagement with the churches. That was the largest community that was reaching out to us to actually get their members vaccinated. One is about trusted sources. That's one area. The second is the benefit. And that's where, we really need to look at who is going to benefit from being vaccinated. And you think many of the church members, not only were they the older population, but it was also most likely to be the working population. As we do notice that we learned, particularly earlier in the pandemic, we discovered who all our essential workers were. And during the lockdowns, who were most impacted by, those who haven't been able to work, the economic impact for those who've been able, had not been able to work, and the economic impact on households for a key breadwinner being infected and being quarantined. And so with that, we saw our largest vaccination uptake amongst that working group population, particularly the 30s, 40s, and 50s. And we can understand why. And also we can see that was the group that was most likely to seek out vaccinations for obvious reasons. And so now we know that if there's a population we do need to continue to work on, it's our younger population. But I do believe we're going to see uptake there. And one of the reasons why is there was a slight disconnect between the initial run of pandemics and when the last round of boosters came on before the bivalent, because we have to remember that last round of boosters were for 50 and older, when you had a large number of people in their 30s and 40s who probably would have received a vaccine if they had been eligible. And so, Dr. Alcindor, you did ask the question about the bivalent. Since it just been released, I think right now we're just dealing with that sort of quiet phase between people knowing that there's a bivalent, but people actually understanding there's a bivalent. What I have seen is in reaching out to the community and going to the community by making the bivalent vaccine and flu vaccine available for both groups, that we're seeing an interesting uptake, that in a couple of events, we had a large number of individuals who actually at the same time received a flu vaccine and a bivalent vaccine. And so I think one of the impacts we're going to start looking at is, one, being available to the community, and then having the shots they want available, knowing that the understanding and the explanation to them will be centered around, not only are this going to help you stay healthy, but this is how we're going to keep you productive. And just to keep things more engaging and interactive, which is one of the reasons why I've decided not to do slides, I'm definitely ready to take additional questions from you, Dr. Alcindor.
Yes. So, Dr. Irvin, can you tell us a little bit about the diversity that you serve, meaning that the impact of the COVID-19 pandemic has been widespread. And we know that communities in need, that is medically underserved communities, are very diverse. And that's a nice looking mobile unit you have behind you.
Thank you.
And how have you used that mobile unit to go after and serve those medically underserved diverse populations in Georgia?
So first I'll say, Morehouse's School of Medicine's mission has always been about addressing and advancing health equity. And so within that mission, there's no community we won't serve. And so we have not only worked with the immediate Metro Atlantic community, which has been primarily, of course, African-American, but we have gone into rural Georgia, such as Barnesville, and that's one of the more interesting venues that we went to. But those who are not familiar with the Georgia landscape, Barnesville sits about an hour and a half south of the Metro Atlanta region. And so it's a very rural community. It's one of the last communities you get to before Macon. So it's a significantly rural community. And then one of the events, we actually partner with probably the largest employer, which is the Continental Tire Company. And our president was so welcome there that even the local health department had deferred their normal vaccinations to send what would have been their clients to us for this vaccination event. And that was a community that, unlike Atlanta being urban and primarily African-American, this was mostly rural and probably mixed Black and white. And we also received requests from the Hispanic community. So I would say that the diversity is growing and increasing. And I am proud to showcase the unit behind us, because even though we ordered it over a year ago, due to supply chain disruptions, something we thought we would have been using over the spring and summer, we literally just received. So it's now sitting in our on our property. Well, this one we just we took it out for a test drive, but we will be actually using this starting. We actually used it for Community Engagement Day last week, and we expect to have it out weekly, again, taking it to the community, because again, what we recognize is have that vaccine will travel, people will get vaccinated. A great example of how this works is I'm old enough to have high school class reunions. And every summer we usually have at least, if not a formal reunion, a cookout or picnic. And we had just did a vaccination event in one part of the city, and I reached out to my classmates and said, would you guys like to be vaccinated? And they literally said, if you bring it, we will take the shot. And so that's when it became apparent that for many in the community, if you have a means to reach them with the vaccines, which is what we're going to be using with the unit behind us, you will have increased engagement in around vaccinations.
So Dr. Irvin, we found that with the Tennessee SEAL and with the HealthWorks Consortium Tennessee, that providing wraparound services for communities in need was a way to get them in the door for vaccinations. Can you tell us a little bit about what HealthWorks Georgia SEAL, HealthWorks Workforce Georgia is doing to include wraparound services for people that need more than just the COVID-19 vaccine?
Oh, that's an excellent question. And that's why we designed many of our vaccination efforts around both our Morehouse Healthcare, the insured portion of our services, but also for those who don't have insurance. So many of our efforts were tied into health fairs. And so with those health fairs, not only were we providing vaccinations, but often health screenings as well, blood pressure, glucose, cholesterol, and other similar health screenings. And so not only was there a chance you could get your vaccinations, but say you were uninsured and turned out to have hypertension and diabetes. We had everything set up where we can actually get you scheduled for our free clinic and making an appointment within 1 to 2 weeks, and then provide that necessary care. And now that we have our social work interns involved, any other wraparound or social services that may be needed, we can look at providing that as well to the people we care for. So the idea is to not only provide the COVID-19 vaccinations, but also do the health screenings and get those who need care engaged in care, or at least provide overall health education as well.
Yeah. So last question, Dr. Irvin, can you tell us a little bit about the challenges that you've had during this time of trying to vaccinate people, particularly those that are hesitant when it comes to COVID-19?
The biggest challenge is being ready when they're ready. There are some people who were ready to be vaccinated, but again, there may have been, if it was now time for the next booster, yet they were under the age of 50, that was a missed opportunity. What was a challenge that I wasn't expecting to happen, but actually, made things very frustrating. There was a window between the previous booster and the new bivalent booster. I know our federal government had good intentions when they announced the bivalent booster, but at the same time they announced the bivalent booster, they made it known that you're not supposed to give the old booster. However, the delivery window between the new bivalent boosters and the announcement about bivalent boosters left a gap where which people who are interested could not get either. And so we lost individuals there. And one of the Morehouse system challenges was the delay of our sprinters, because as you can see, this was a nice way to promote, not just Morehouse School of Medicine, but also have a very visual tool to see that we're out in the community. And so that made it a little challenge to catch people's attention, so to speak, that we're here, we're ready to provide your healthcare without, the nice little flashy vehicle to really catch their attention and bring them in.
Yeah. So Dr. Irvin, I have another question, and that is, monkeypox has had us on the run, gave us quite a scare. And the idea is that we're just calming down, but we don't know if this will be something that will be a problem going forward. Can you say a little bit about what Morehouse has done to try and calm the nerves of people that are asking a lot of questions about monkeypox?
Thank you. And should we plug the podcast you and I did together to address this?
Absolutely. Absolutely.
And so please, everyone, do check out the HealthWorks podcast. And one of the podcasts, Dr. Alcindor and I did actually talk about this. But yes, Morehouse School of Medicine is also, doing the necessary community education, talking to the community about monkeypox. And one of the communities we're definitely targeting is our young, and let's just be honest, sexually active community. So I, through my efforts in the Morehouse School of Medicine Student Health and Wellness Group, we have been doing education sessions around monkeypox. And for the undergraduate students in and around Morehouse School of Medicine and AU Center, actually providing monkeypox vaccines to that community, because we do know that this is a group that's active and often in not necessarily sexually intimate spaces, but in close contact and intimate contact in that general engagement. So we definitely wanted to make sure that they understood what their risks are, who need to be vaccinated, and making sure they're properly educated. And when I have my students out in the community, we do the same thing.
Excellent. Thank you so much.
You're welcome.
All right, all right. Are you able to hear me well?
Yes, go ahead.
All right, wonderful, wonderful. Well, good afternoon. I wanted to spend some time just talking a little bit about the response from the state of Tennessee in terms of how we responded to the pandemic, and then a lot of what we've built to be a sustainable response to whether it's the pandemic or future challenges that we may experience across the state. But before I do that, I wanted to kind of put it into context in terms of the work that we do at the Tennessee Department of Health. And so across the state of Tennessee, Tennessee has 95 counties, 89 of which the state of Tennessee truly has some oversight in terms of healthcare. Out of those counties, we have a variety of extensions, meaning our safety net partners, a variety of other providers that support the system of care within those 89 counties. We have 6 counties across our state that are primarily what we call metro counties, whose health departments are controlled by those local governments. And so usually the mayor's office really dictates what happens in those counties. And so what that means is that we started off with a complex infrastructure in terms of how we coordinated the response to COVID. Within our 89 counties and our health departments in those counties, we have about 100 health departments. However, we only have about 49% of the workforce working in those local health departments, and only about a third of those personnel within those health departments are clinicians. And so we started off again internally across the state with few supports in order to be able to respond to the need, whether it was for testing, and then when we moved into the vaccine proportion of the pandemic. And so that's just kind of setting a framework. And then also our challenges before the pandemic was that the state of Tennessee, again, amongst those 95 counties, only 4 counties had sufficient number of personnel, whether it's medical personnel, whether it's physicians, dentists, mental health providers, in place to be able to take care of the existing populations. And so we started off with a variety of shortage areas across the state. And also only 4 counties across those 95 counties in the state of Tennessee had enough services available, health services, whether it's pediatrics, primary care, dental services, and again, mental health services in place in order to maintain the capacity. And so we started going into this pandemic at a deficit. And so then you're hit with a variety of need. You're losing workforce, you're losing the capacity to care. We started off at a deficit. And so our response initially was that we had to quickly try to identify the most vulnerable population. And at that time, in late March, early April, we identified that our, again, similar to what we saw globally, is that our seniors was more at risk. And so we had a quick response, immediate response to support our seniors in terms of making sure we're doing outreach, making sure we're figuring out systems to be able to engage those populations. However, we did not have a process or a framework in place across the state to be able to engage our communities of color. And so the data, of course, shows that our communities of color were hardest hit. In the state of Tennessee, that is approximately 30% of the total population. However, they comprised a little over 70% of the cases at that time, but we had no response in place for that. And so the challenges we faced was, what was going to be our strategy for reaching out, engaging and supporting the needs of our most vulnerable Tennesseans, our communities of color, our disabled communities, our communities with language barriers and all the lack of technology divide that we see across the state. And so the governor established my division. I lead the division of health disparities elimination. This was not in place at the time at the beginning of the pandemic. We were established a little in about a month into the pandemic, or around April. This office was established to really try to figure out a strategy for reaching, engaging our communities of color. Again, we did not have that infrastructure. We're starting off at a deficit. And so it was really hard to figure out the best approach. And so I now lead the Office of Minority Health. I lead our rural health office. And then during the pandemic, we were able to create our Office of Faith-Based and Community Engagement, which was huge for us to be able to work with our community partners, work with our faith community, and then also build partnerships external to the Department of Health to be able to maximize the workforce that was available. Again, we were about 1/3 of our population, of our 49% is our clinicians. And so that's whether there's physicians, nurses, medical lab personnel. And so we did not have enough staff. And then within that, they only exist in 50 of those counties. And so we have a majority of the state with no clinical support and no infrastructure. And so I wanted to go to that second slide where I was showing our medical personnel. A lot of the work that we were able to do was to first, really, that slide, yes, to rely on our community partners. And so this is just an image showing our governor, but also with our community partner clinicians. And so my rural health office, we fund approximately 108 safety net providers. And these are our providers across the state that really support us as an extension of that system of care to provide healthcare to, again, our most vulnerable, meaning our uninsured Tennesseans, adult population. We relied heavily, and I would say probably about 89% of the effort either came from our academic health partners across the state, like Meharry and University of Tennessee and East Tennessee State University. And so a lot of that, but the majority of that care and that support and all of the outreach, the testing and all of that work really stemmed from the effort that comes from our safety net providers. And so they rallied up, they were in the tents, they were on the ground, really being a truly an asset to us being able to get that work done. Throughout the pandemic, as we've gone on, we are really relying on a lot of resources that the CDC has really provided to the state. For my office particularly, I rely heavily on community outreach workers that are both working to support our work to address vaccine equity. We have those not only working to be on the ground, to be build those trusted voices, and to be those trusted voices, but to build that that trust in across the state in terms of what we're trying to do with maximizing vaccines, continuing to provide some extensive increase in access to care. Our community health workers have been truly an asset to that. We are currently utilizing community health workers in the form of continuing to support vaccine events. We are still providing COVID-19 vaccine events. We are also providing monkeypox vaccine. We're into flu season, and so they've now become a continued support system that we have to deploy the resources into the community as we move forward beyond COVID. And so what we also are doing is we have community outreach workers also working in the space of really working with our providers. And so whether they're safety net providers or they're private providers, really trying to encourage our providers to administer vaccine, to receive vaccine, because really right now, as it relates to monkeypox, we have a number of providers that still refuse or do not want to have that vaccine at their locations to be able to administer it. And so it creates kind of a bottleneck at some of our local health departments in order to be able to administer that. And so we are still doing a lot of work currently with encouraging our providers to continue to support COVID, to continue to support all of the other vaccine needs, whether it's flu, and to do their part in terms of making sure that they're encouraging the patients to take these very valuable vaccines. And so still struggling. Tennessee, it has still, we still face challenges with misinformation. That has been a challenge before COVID and really throughout the pandemic. And so we're still struggling. And we're still trying in some of the areas across the state, trying to really build that buy-in for understanding why this is important. And it's showing and it's reflecting in the data that we see across the state, and where we're still seeing that the majority of the deaths in the state of Tennessee are happening amongst our white, rural, really northeastern part of the state, where it has just consistently been a challenge, and refusal to whether adopt, the testing efforts were a challenge. The COVID initial rollout of the vaccine, and then currently anything else we try to roll out, whether it's flu or anything, standard that we typically addressed in public health that we have to roll out. We're still facing that challenge of misinformation, and continue to do our part. We're trying to, rally new partners all the time to kind of join the work that we do, to be able to support continued efforts in that space. And so a few ongoing strategies that we have in place to continue to not only support COVID-19 efforts, but again, we were able to really build partnerships and all kinds of resources, pull them together to be able to continue to support COVID-19, but then everything else we think of. We have to think of really what were the needs of our community prior to COVID, and to make sure that we have systems in place to be prepared and better prepared to be responsive to the needs of the community, which we've grown over time to be able to do that. But one key strategy that we have that's an ongoing strategy is our Health Disparities Task Force. Our Health Disparities Task Force was created in the height of the pandemic around 2020, around May, early part of May, into April, early part of May. And it really started off with 70 members who were across our academic partners. There were a couple of local government officials who were at the table to support, and then a few members of the community coming together to understand what the local challenges were, to be able to help the Department of Health frame strategies to improve that outreach. That Health Disparities Task Force has grown to about 1,400 partners that we have now across the state in both our urban and our rural communities. And so it's been huge. We do have a lot of state officials, local government officials. We have academia at the table, our faith communities at the table, and our local nonprofits and members of those communities, really meeting on a regular basis, continue to help us monitor the progress that we're making with COVID, and then also help us understand where the gaps and the needs are. And so this is an ongoing strategy that we have to make sure that we as the Department of Health, as the government, are not really siloed in terms of how we are thinking in creating programs and initiatives and deploying those into communities. We're making sure that we're including our community partners as a part of that development of those initiatives and those strategies, and making sure also that we have a vehicle for funding that. We also were able to, again, sustain our work with our community health workers that we initially received via the CDC. They've been a very huge asset to the work that we do, and we have a lot of resources that funding-wise we've received to be able to sustain that work and really build them into the infrastructure of the Division of Health Disparities Elimination and Minority Health, where that workforce was not part of the work that we do. What we're also doing is we're creating opportunities across the 3 grand divisions across the state. And so West Tennessee, Middle Tennessee, East Tennessee, and embedding within each of those grand divisions in those regions, community health workers. We have also health educators, a lot of focus on health equity and diversity and inclusion. Again, these systems were not part of our initial rollout of during the pandemic, but we've been able to build these systems and be mindful of equity and the needs that we have across the state. Where we are now is we've received a significant amount of money from the Center for Disease Control, CDC, to be able to again create some implementation strategies across the state. And so what we have to do first right now is build the capacity of our state of Tennessee to be able to do and be more responsive to any need that occurs that really creates a challenge for our communities of color. And so what that means is that we are now utilizing our churches, our community organizations to be, again, extensions to not only the Department of Health, but up to the extensions to our safety net. And our safety net, again, we have clinics all over, whether they're community faith-based clinics or they're FQHCs all across the state, but they also need to be able to be to have more capacity to mobilize. And so we're mobilizing workers into churches. We're training folks in our churches to be able to, again, be those trusted voices to be able to support the needs there. And so a lot of work is happening. A lot of work has been built. A lot of work is being sustained, and we're really proud of the efforts. We're seeing now, from a disparities perspective, is that we are continue to see increases in both vaccines administered to our communities of color. African Americans, I think, are around 50, a little under 50%. And then for our Hispanic community, really seeing a huge uptake, a little over 66% of that population being fully vaccinated. And those are huge wins considering where we began, and then the short time we've had to really build a sustainable approach to addressing COVID-19. And so if there are any questions, I would love to.
So I just want to ask you, of all of the 95 counties in Tennessee, and a majority of them are rural counties.
Yes.
Many of these rural counties, some of them have poor broadband internet access, so they're not able to access telehealth services.
Yes.
Some of these counties are very conservative, and you have a lot of hesitancy in terms of vaccine hesitancy in those counties. Now, with the infrastructure in rural counties that have been degrading for many years now, what are the departments of health doing to support the effort of trying to get through the vaccine hesitancy barrier that exists in rural communities in Tennessee?
Oh, so yeah, so vaccine hesitancy has been and continues to be a challenge, as I said before, particularly in our eastern part of the state of Tennessee. What we learned early on, and again, a lot of the infrastructure I go back to that we did not have in place. And so again, at the start of the pandemic, our efforts were solely, let's put it on Facebook, let's put it on the internet, and realize with no conceptualization that they had no broadband access. There was no way for them to get that information. And so what we had to do was really, I had to hire a team really that went out. Again, I lead minority health and rural health. And so hiring teams of individuals, train them as community health workers, and get them on the ground. And so we really created a grassroots campaign to be able to do that. We had folks knocking on doors. We identified communities that at the start of the pandemic or prior to the pandemic, we had never engaged in any form or fashion in any programs, any project, whether it's tobacco cessation or any of our maternal health outcomes, and identify new populations of color that no one, this is coming from the community, that had ever been engaged. And so talking to pastors and talking to leaders in those communities, and the state had never prior to the pandemic reached out to those communities. And so again, our grassroots efforts started because of that lack of access. We have received a ton of funding, and we're putting a little over $3 billion into expanding broadband access across the state so we can improve that. And we're seeing that work begin. But it really takes identifying those key leaders in those communities, those trusted voices in those communities, and bringing them along as part of this team to be able to do that work. Because for me, going into East Tennessee State, East Tennessee, a part of the state, they're not going to listen to me, but what they will listen to is a local leader, someone that is from there, trusted there, and continue to use them. And so our strategy is to maximize partnerships. Again, I spoke to the fact that we started with 70 partners at the beginning of the pandemic, and we've grown that to 1,400 partners. And so that's a testament to the grassroots efforts that we put in place. They're out there, they're building, always, every day we're making new partners, and we're using them to help us address it.
Okay.
So again, you trust what's local. Yeah.
Yes, so I want to open up this to the panel, these questions. We've seen this happen before, where there's a calm before a storm. We've seen surges come out of nowhere and put us back at home, put us with masks on again. What are the strategies from the lessons learned for all of you professionals that are on the panel that you would do differently or do in addition of to support this happening in the future and for future pandemics that might come? Anybody can start.
I mean, I'll just start. I'll just say, we really had to deploy our outreach workers, our community health workers immediately. I think that a lot of us who have been doing this community engagement work for some time, we already were champions and familiar with community health workers and outreach workers. And it's just, lately, that, on the national scope, you see that more champions, coming on board. So I think that if, we had that before, we would have immediately been able to deploy train and deploy outreach workers, really kind of get the message out, so I think another issue was getting a trusted message out to communities, and something that we could have done much faster. So I'll start, and I'm sure you guys can add.
And I will add, when we get that message out, have the message relevant and understandable to the community. Dr. Lizana and I work very closely together, and we often joke with each other, being both public health individuals and data people and all that we see things and it's like, I barely understand this. How do we expect the community members to understand the same thing? And we know this from actually doing the high school and young adult community health worker program, where we were training young people who had no medical background on healthcare and healthcare issues. And we recognized very quickly they can understand the material if the material is delivered in a way that they can relate to. And so too often we have wonderful health information, but we don't know how to convey it to people in a way that they can actually act on it. And so that would be one of the key things we have to do. Whatever message we create, use the resources out there, the retail industry, the movie industry, the entertainment industry. They do an excellent job conveying messages. We need to learn those skills from a public health standpoint, so people will follow. Because if someone can do a TikTok video and have people eating Tide Pods, if we can get people to do things that just obviously aren't common sense, then I'm sure we can develop messaging for people that actually is beneficial. And so that is one of the key things, and to help people see the benefit of it. It's hard to get anyone to do anything if they don't see any benefit within themselves.
And I'll speak from a state government perspective, is that, I think where we failed is that we had one approach to addressing the pandemic and the needs of the communities, one approach that we were just going to deploy across the state to reach everybody. But what we failed is that the state failed to realize that every community is unique, right? And we had to consider the unique nature of who we connect with, where we connect to them, what resources they need, where they started from. Again, gaps. We were already deficit from a workforce at the beginning of this pandemic. But what we also had were communities who did not have access to care. We are second across this the country in terms of the number of hospital closures, and all of those have been rural hospitals. And so there was no connection point. So we didn't have those systems in place. And so also failing to understand that even the response to pandemic, the number of cases, hospitalizations, deaths differed by race, and we didn't have a system. My Office of Minority Health at the height of the pandemic was essentially 4 staff persons to reach 30% of the whole state of Tennessee. And so we had to do so much building, right? And that we need to be mindful of that, and put some resources in to support this system that we've been able to build and sustain it. And I think a lot of states, particularly in the South, struggle with that, is that they had a one kind of stop approach to addressing the pandemic and not considering the unique nature of each community and being able to really to support that resource-wise. So I think we need to encourage states to consider our communities of color, consider our vulnerable populations as priority.
Thank you, Dr. Lamar. We have a question from the chat. the question is, how are you been able to combat some of the myths that have arose? Many of my friends have gotten vaccinated because of the word vaccine, and there seems to be so many boosters. I was even told that the definition of a vaccine was updated because of COVID-19 vaccinations not doing the same thing as other vaccines like chickenpox, MMR, and so on, which I didn't know. Is that true? And what do you say to someone who is hesitant? That's the question from the chat. Anybody can start.
Go ahead, you know you want to, Dr. Urban.
Myths are hard. I mean, particularly when there's just enough truth in it that there's always a plausible deniability involved. What I've learned is, oftentimes to use examples, analogies and whatnot to help people realize that, oh, that person didn't quite have it right. And it definitely helps that it's someone that they trust and can explain things to them in a manner that makes sense. For me, vaccines are vaccines. And what it is just helping people explain, understand that vaccines are a tool and the series of tools to keep us healthy. In the case of vaccines, I've used, the analogy of a seatbelt. A seatbelt is not going to keep me from having a car crash. The seatbelt is going to keep me from being more injured in case a car crash happens. Similar to the vaccines, it's like the goal of the vaccine is to minimize your risk of getting the disease. The nature of the virus determines the likelihood of that happening, which is what we discovered with not only COVID-19, the same thing with the flu. And to the point where even like the students have asked me, how do I explain this to a patient? And so that's what we do, try to find a language that is receptive to the person listening, that overrides the misinformation or the half-truths that they're hearing. And often, and just relate it to something that they do understand. And anything from you, Dr. Lamar, as a government representative, and I know you face this often, with even more limited language options.
Well, yeah, we continue to, again, without kind of, we politicized a lot of this pandemic, and it's unfortunate. And I think some of that is playing into our ability to even penetrate some of the misinformation that we have in some parts of the state. But again, we're making headway, because I think what we're seeing is that it's shifted. We saw that significant shift in terms of who's dying. And I think that made a role. When it was, again, I felt as if when it was a lot of Black and brown people dying, it wasn't that important. But now that we have a lot of that, majority of that population vaccinated, and we're not seeing it. We see mild cases amongst, the communities of color, but what we're seeing is less deaths, and we're seeing more deaths in our white community. And I think that's leading to some, penetration of that misinformation and starting to see some changes. And so we're bringing more and more of those partners in that space to the table. And so I think it had to take a shift in how this pandemic was really playing out. And I think that unfortunately has helped us address some of the misinformation and get the buy-in for the vaccine. And so it's just our state, the way it's laid out, it was there before the pandemic. So this is something, again, that's just ongoing. The flu, no matter if you go back 10 years and you can look at social media, you talk about the flu and you talk about any type of vaccines, whether it's childhood vaccines, you get that. And so that's just an ongoing, that's part of our nature. So we've learned how to navigate it over time.
Yeah. And so we know in this pandemic, we've had a lot of different vulnerable targeted populations. And so particularly, I want to talk about what you've been doing to help or support targeted populations in terms of getting them vaccinated, giving them information to improve vaccine confidence and uptake. In particular, I'm talking about those individuals that are unsheltered, homeless, pregnant women who are not getting the vaccine as often as they should, and of course, those migrant populations, possibly even refugees that are coming into the communities from other places. Can you speak to that? Anybody can start.
Yeah,
I
I'll
will,
just, I'll start generally and then I'll kick it over to Dr.
that
Urban. So
works.
just in general, in terms of the trainings, so the outreach worker and the community health worker trainings, I emphasize the importance of motivational interviewing, talking to disparate, populations, making sure that we have materials, for those populations. We also have monthly strategy sessions, to really kind of brainstorm and talk about what the outreach workers were seeing in the field. So as they're encountering these special populations, and what should the messages be? So just kind of to give a general scope of the outreach worker training. And then Dr. Urban, I'll kick it to you.
And I'm going to sort of take care of two questions with one stone, because also I responded to this question that was in the chat window that also asked, how do we address that in-house? And so first, we really, particularly since oftentimes we are the outside individuals, even though we may be a trusted institution, we're still strangers to many of these communities. So we depended on our community partners, and we try to have a very diverse and broad set of community partners to help to reach some of the populations that you spoke of. So that was one of the reasons why my church community was great in many regards, because some of the churches we work with either reside in communities where the unhoused and the under-resourced and under-income reside, or that's part of their mission. And so for some of those communities, that's how we reach them through our community partners. Regarding the refugees, we actually have been actively trying to reach some of the refugee community, and it's just timing, being able to line the time when we can reach them versus when they're ready to receive those services. And so we do expect to at least be working with one group here in the metro region, survivors of torture. We've been in communication. We just haven't identified a day when we can come out to do vaccinations with them. And we are planning to work with the migrant community, both with the Georgia SEAL relationship. We've targeted migrant communities, and we just actually had a meeting to see plan for us working with the migrant communities going forward as well. So we do recognize that there are many unserved and underserved communities that need to be targeted, and we're working with our community partners to reach those organizations. Even within the metro region, we have two Latinx partners that will have us do vaccinations with them forthcoming.
Thank you, Dr. Irving. And again, as we move on, we want to try to keep the answers short and to the point. And so we have a number of questions in the chat here. One question: was there special trainings developed for reaching certain vulnerable populations and special populations, pregnant and nursing mothers, persons experiencing homelessness, and migrant workers?
So I mentioned the general outreach worker and community health worker training as far as motivational interviewing, and this strategy sessions that covered those populations, but maybe Dr. Urban or Dr. Lamar can add to that if they would like.
So at the state, at the Department of Health specifically, we have, addressed health equity kind of as an overarching goal across our strategic plan within our department. What that means is that we are now deploying education, training, understanding implicit bias, and all these things, having real true conversations that we had not had in the past. And so a lot of opportunity has come out of this pandemic. And so ongoing training is ongoing, particularly as we're trying to get our workforce to understand the culture, the leaders, the systems of leadership within certain communities, and how to navigate that, and again be able to engage with them effectively. And so we have this as a training of course, it's ongoing. we have made specific hires. We hired now, we have a new immigrant refugee specialty health educator that is working out of our office, that is also working on ground with some of our grassroots partners and some of our health partners across the state to be able to understand communities and understand, again, those systems that are already in place and how to navigate within that. I think that's just ongoing learning. This is new, and we now are really seeing a huge engagement. And the other thing I want to say is part of our ability to engage stem them across their ability to trust us. We are the government, and particularly when you're thinking about our Hispanic community, our other immigrant refugee communities, they don't trust us, and they didn't trust us, right? And so what we have to do was really identify systems to really build that and establish that trust. So working across our faith community has been a huge asset to be able to, for us to be able to penetrate those communities and build that trust. And that's what we need to get anything done.
Okay, so we have another question in the chat. For some strange reasons, generally speaking, young people still think they're invincible. Any words of wisdom to guide them along the vaccination journey?
Yep, that one's, that's ongoing. So this past weekend, I just, came from my homecoming at Spelman and Morehouse, and, there weren't a lot of masks, to say that, so that's definitely an ongoing challenge. We partner with Black Girls Health Foundation, and part of, what they do, they have trained and deployed college ambassadors, and really we just need more of them. To talk to students on campus. They employ a lot of methods, social media methods, and TikTok, spoke about that earlier. And TikTok seems to be things that they listen to, so trying to, make them fun as well, and the messages that are geared towards them, and so we just really have to continue. We definitely need to train more college ambassadors. Yeah.
I agree. The college ambassadors have been very huge asset to us. But I also think too, we have also utilized individuals' personalities that resonate with them, whether those were musicians, rappers, athletes, others that really we can bring along as trusted voices, and to be able to share that message and encourage that younger demographic to buy into these resources that are available to them. And that has really worked. And so creating events too, where they can engage around that. And I think, we utilize that method in a lot of other things, like getting, registration to voting and all these kind of things that have really worked. And so we deployed that strategy as well.
Yes, it definitely has to be peer-led, which is why it's been great to have the MSMS students be part of these vaccination efforts, because they are of that age group, and so they can only talk to their peers, but their peers can see them being part of this process. And so it truly has to be youth-led to get that youth engagement.
Okay, yeah, we have another question. We have another question in the chat, and that question is looking at the role of social media in HealthWorks initiative. Will it be grassroots, person to person? Where is it going in the future for this pandemic?
I think it's a combination of all of it. I think we need to keep all of these types of systems in place, particularly as right now we're still in the process of trying to make broadband access really accessible to all folks across the state. And so that's an ongoing process. And I think we're going to have to, in some form or fashion, utilize all of these different types of approaches. Because remember, we all have different communities, different needs, different resources. And so making it multifaceted will be a continued process as we continue to move through this.
Okay.
And definitely keep it going and building up the network. I hate to use them as an example, but they shown how it's done. It's the right wing community. They have developed a network, so whenever they need to get a message out, they are ready to have their message roll out at the drop of a hat, and reach their targeted audiences very quickly. We have to learn to develop our public health social media networks such that we always have a message ready to roll out, whichever platform is the popular platform at that moment.
Yeah. A general question I have for the panel is that we know that from the beginning of this pandemic, there were certain people that had lingering symptoms that went beyond 4 weeks, went beyond 12 weeks, and beyond a year. This is referred to as long COVID or post-COVID syndrome. And the idea is that this could be around a long time for some folks. Some folks are suffering from this. Being able to get into specialty clinics have been difficult, particularly for underserved minority communities. What are you doing to support efforts to know more about long COVID and to address long COVID through your partnerships and your institutions? Anybody can start.
I'll start this time. This is going to be an interesting one, and I'm going to even take a time because I don't think we got into that question. I don't know how much time we have left, but this is even a great chance to even talk about response to someone, why should I even get vaccinated? And so I put in response to that person's question, one of the things the media has sort of moved on about, I guess because of the midterm elections, people are still dying from COVID daily. To the tune of several hundred a day are still dying from COVID daily. And most of those people are the unvaccinated. But the other thing that's not being discussed is the individuals most at greatest risk for long COVID are those that are unvaccinated. So if there was any reason to get vaccinated, that'll be one of the reasons, is to reduce your risk for long COVID, because that is an area that I don't think anyone really has a handle on. I know the goal is, goes to research with Black and Brown communities in general, is having trusted institutions like Morehouse School of Medicine and Meharry be at the forefront of doing the necessary long-term studies regarding things like long COVID, because it falls into the realm of probably some level of autoimmune disorder, which we are already behind on in research. So this would be a great time to look at what's happening with long COVID within our communities. And I believe leveraging that to even spin off other research topics, because that's what's going to happen in the other communities. They're going to use their research dollars to look at long COVID within their communities. And this is a great opportunity to see what is unique about our communities, why we're at risk, and then even use that to plan for longer term health strategies for us. Everything from whole care, from pediatrics to geriatrics, whole care within our communities, wraparound services and comprehensive services from nutrition, wellness, and whatnot.
Okay. So I even tempted to jump in on my own question there, but I held myself back. So I wanted to ask you this particular question, and that is new technologies, because people are doing a lot of things to look at COVID and to monitor COVID over time to see if they can get ahead of the next wave, the next surge, the next pandemic. That is monitoring sewage treatment, doing AI and machine learning to try and learn more about COVID and how it's being transmitted and the likelihood of how the virus is changing. Are you doing anything in your institutions to support technological changes that would allow you to monitor COVID over time and to be able to get ahead of this pandemic before it becomes entrenched in communities, causing disease and death?
I'm going to ask Dr. Lozana, our data scientist, to weigh in.
Well, actually, I was just going to say that in the concurrent sessions this afternoon, those things will be discussed. So we have our Satcher Health Leadership Institute will talk about their health equity tracker. And so, it's tracking health disparities, but in addition to COVID, as well as Ashland Management Group will talk about their data dashboards as well. And so we know, we have to use data and we have to be sophisticated, totally to eradicate COVID, but also to pay attention to the other health disparities. I mean, I think one thing that came out of this pandemic is the focus on health disparities in general, knowing that, we need to use the same technology that we're using to combat COVID to use those to combat health disparities.
Yeah, thank you. And this is again for the panel. Is there any stories that you have come across during your fight against the pandemic that made you think and wonder that this encapsulates the pandemic as it exists in these communities and what we need to do and why we're doing what we need to do?
So I can start there. Our office, our division actually, throughout the pandemic, we created a program, what we call, or an initiative, what we call, I'm sorry, I'm trying to think of what it is. Community Voices, I believe that's what we titled it. It's on our website. We collected stories across the state from individuals of color, but from all types of communities across the state, and allowed them to write their story, share an image, really talk about how the pandemic impacted them, their families, their communities, and be able to post those stories online. And so if you get a chance, you can go to our healthdisparities.com website and be able to review some of those stories, some great submissions that we received. Where we are now is we're creating a documentary really to document the impact of COVID across the state of Tennessee, particularly focused on our most vulnerable communities, whether it's our disabled community of disabilities, our communities of color, our multifaceted immigrant refugee community, and really document, the impact this pandemic has had on those communities and allow them to really share. But also want to hear from our providers and again, our church and our faith communities to allow them to share how their institutions also have been impacted. And so that's something we want to archive and document this history, because this is important to remember where we started, where we're coming from, and then where we're going. And so those are just some things that we're putting in place at the state.
I'll do two stories. First, one that's on a not so great note, just how the pandemic just impacted so many people. Dr. Lizana and I also work together on a leadership program. And so it's a fellowship training primary care providers in leadership. And during the between the height of the pandemic and the initial vaccinations, the trials and tribulations of training primary care providers to be leaders, at the same time helping them navigate them dealing with family members who were severely impacted, if not had passed from COVID. And so that's what some of the sadness of it and the importance of getting people vaccinated and understanding the impact this can have. Two, being out in the community and doing a vaccination event and hearing how particularly, community members saying, I'm getting vaccinated so I can see my parents, or I'm getting vaccinated so I can see my grandkids. Oh, are you guys doing vaccinations today? How long are you going to be here? Let me go home and grab a family member. Let me call a relative or our to get them over here to get vaccinated. So we learned that, of course, there have been tragedies during this pandemic, but with our vaccination efforts and our vaccination education, that when people have had the opportunity, they have taken it and benefited from it.
Thank you. There's another question in the chat. Do you believe that people in general have stopped getting vaccinations? Certain diseases have popped up again, such as polio. Now that monkeypox is on the rise as well, what do we tell people who are ignoring COVID now and have moved on to these newer but forgotten about threats?
Dr. Irvin, I know you don't want to talk about it. Well, we just talked about this like a couple of days ago. How people are asking for monkeypox vaccinations more than COVID vaccinations sometimes.
It is always going to be the latest fear. And I guess I have to use my HIV, STI background as well. And what I used to tell people, there have always been a sexually transmitted infection. Once we found a cure for one, another one popped up. And so you can't forget the basics of all of these, because then they eventually come back. And it's interesting to see that not even syphilis is running back, just as we're on the cusp of getting a handle on HIV. And so we have to take that same approach with the viruses, is to help people understand that just because the latest and greatest has hit the horizon, the other ones have not left. Because I think many of us are old enough to be, to be like, really, polio, of all things, to really come back, polio. And so it's to remind us as healthcare providers, public health officials, community individuals, is that we can never get too distracted by what's on the horizon with what still exists, and just really helping people to understand that just because something is here doesn't mean your risk for the others are lower. I have never seen the public health community as nervous about the flu this year as before, because it's the same fear. Just because monkeypox is here and polio is here, no one's worried about the flu. And I don't know if we're ready for that. So we really have to get that communication out there, that we need to be always prepared, always vigilant, and remind everyone, those basic things work for many of these viruses, frequent hand washing, minimizing enclosed spaces. If you have any health risk, use the mask. They got cute masks now. I'm mad I still have a white mask when I could get color coordinated masks. And even look at young kids, have some of the resiliency that our young kids have. Little kids have been moving fine through this, much better than adults. We may need to talk to them to see why do you wear a mask? Because it's cute, it's fun. I can get a Minnie Mouse mask. I can get a Little Mermaid mask. I can look cute. So we need to really just engage people to help them understand that preventing one will help us prevent many of these. We just have to be willing to do so.
Okay. Okay, the next question I have is that we're trying to vaccinate children. As young as 5 are eligible now for the bivalent vaccine. And again, we have to try and engage parents. And so engaging parents have been difficult to get them all into a room, because we can't sit a 4-year-old down under a hot light and say, here, I want to give you a vaccine. So we have to engage parents because of consent. What are you doing at your particular institutions in your effort with HealthWorks to try and engage parents and give them the information they need to help them make an important choice to vaccinate or not vaccinate their children?
So I think for the state and for Tennessee Department of Health, I think we're kind of challenging our ability or our capability to reach out to children and to encourage vaccines. We're limited, I'll put that way, in our ability to reach out to encourage vaccines amongst kids. But what we do is we do reach out. We have to reach out to the parents, and we have to reach out to our providers. I think a lot of that that uptake of that vaccine will start with our providers. And so as much of that we can continue to engage, we'll start to see some uptake. I think, again, we have some specific efforts that are in place to reach out and address the need, the equity and the need for equity and the need for vaccines amongst our children. But directly, we're not doing a whole lot to encourage the newest vaccines for COVID amongst kids for a variety of reasons. So.
Dr. Lizana and I are definitely working together on this with our pediatric colleagues. One, we had actually even considered that we want to even try to do this in the community, and we recognize that one, engaging parents with kids out in community is already challenging. It's called keeping their sanity, but we are at least trying to make it engaging and beneficial to the parents who are part of our pediatric practice. One is, seeing how the pediatric practice is already challenged with getting patients back into care. So one, facilitating getting our pediatric population back into the clinics. That is one of the things, we're trying to work together with, and then making it beneficial to the parents. I don't always, am a fan of incentives, but when incentives are beneficial and worthwhile, yes, use them. And so we're trying to even provide things that are worthwhile to the parents or to the kid, depending on the age group, to make it a much easier process. I think, as Dr. Lozano said, we're offering diapers and diaper bags for the infants. Given how expensive diapers are, I mean, that is, a nice balance between having, to make the effort to bring my child in for another shot, but also if I'm going to do it, at least I'm going to leave with something. And so, those are the efforts in, just seeing how we can make it engaging, entertaining, and even as I was informed of a practice I heard from one of the summits I attended, seeing how we can even make these like group visits where multiple families can come in all at once, get the care they need, and then use that as an opportunity to vaccinate also.
This is our last question from the chat, and that is, maybe it's a comment. If COVID had skin eruptions like monkeypox, there would be an increase in vaccinations. And I just want to say that COVID, there are skin eruptions associated with COVID. They're not very, they're very rare in some cases. And so anybody can address that.
Oh, I definitely agree. If it was something that was going to impact someone's relationship, yes, that was one of the most interesting questions I received. Am I at risk for monkeypox? And it's like, I think your lifestyle has you safe. Because we know that monkeypox was due to intimate contact. I won't say necessarily sexual contact, but intimate contact. And if your environment was such that was not going to be a risk, why are you asking me about monkeypox, yet you're going to the stores and the malls and clubs and parties without any masks, but you're not worried about COVID? And so it's sort of a revelation of what people think their risks are. And so, yes, I think if the mechanism of infection from COVID was a little bit more intimate or a little bit more obvious, yes, probably there would have been an increase in vaccine uptake. But I will say it is, again, helpful to remind people your behaviors do impact your risk. And the things that can reduce your behavior, your risk from COVID, reduces your risk from colds, reduce your risk from flu, reduce your asthma exacerbations. That's one of the things we probably haven't done a good job of communicating is during the period of the lockdowns and whatnot, we saw a tremendous decrease in respiratory related illnesses and other illnesses that usually result from close human contact that we suffer from on a regular basis.
Yeah. So I'm going to close this session. We have had a dynamic exchange with experts in the field. We appreciate your time today. We've talked about a lot of things that we hope will help people out there that have questions about how to deal with COVID from a policy standpoint, from a community engagement standpoint, from helping individual targeted populations that have to deal with COVID every day, to providing wraparound services to bring people in the door and at the same time ask them if they would get a COVID-19 vaccine. We have talked about vaccine hesitancy, vaccine resistance, we've also talked about this in communities of color and other communities as well. We've talked about rural communities in Tennessee and Georgia and how they have been very conservative in their approach to COVID-19 vaccinations and how we need to do more. And I think that's what we need. We need to do more. But all of the things that you're doing have made a clear difference for the people in need. And so we applaud all of your accomplishments, and we ask that what can we do to help you do more? We want to thank you for joining us today for this session, and give an applause to our expert panel. They've done a fantastic job.